it on inspiration or expiration that I heard it. Okay? And so you have to listen really, really clear. And sometimes you have to say to your patient, leave it in that same spot and have them take another breath to hear it sometimes, all right? Because sometimes what they do, you're listening and they're just talking away to you and you can't hear anything that's going on. So occasionally I have to say, can I just have you you can tell me that in just a minute. I need to really listen, okay? And they'll say, oh, sure, And sometimes they do good for about one breath and then they're talking to you again, okay? So you have to work around those kind of things. Now, once I've finished my respiratory assessment, I'm going to ask her if she's had a cough at all.
Yep.
And if she has had a cough, and if I've been in the room and I'm going to observe if she's coughing, I want to note if it's productive or non-productive. If it's a productive cough, she's going to be spitting up some kind of sputum. And with that sputum, I'm going to note the color, the consistency, the amount she's spitting up, and what did I leave out? Amount of that, okay? And note that as well. Those are all important things. Any drainage anywhere, right? All right, then I'm going to move on down to her abdomen, and I'm going to look at her abdomen just by inspecting now. Remember up here we did inspection, palpitation, auscultation for cardiac and respiratory. When we get down to the GI, we're doing inspection, then auscultation, then palpitation, okay? And that's something you always remember, that's different. Inspection-wise, I'm looking at her abdomen. I expect it to be flat. Non-distended is another way you can say it. Flat, non-distended. And I expect it when I palpate that it will be soft. And it should be pink. Her abdomen area should be nice and pink. Okay? And so then I'm also looking at her umbilici. I'm going to see if it's inverted or exverted. It should be midline, her body. I may see when she's laying flat, and it's not so much if you have their head elevated, but if you're laying flat and you're looking at your abdomen, sometimes you can see pulsations that is up above, about maybe an inch or two above the umbilici. They can be an aneurysm. Some students went home yesterday and saw it and thought they had aneurysms.
Oh.
But a healthy person that's thin, you may still see that. All right? Hope that relieves some of your mind. Anyways, and so we won't want to, if we see that, we do not want to palpate and push on that, all right? But note it as well. And then as I've checked all of that out, now I'm going to palpate. I'm going to auscultate. I'm going to listen in her abdomen. You should know the 4 quarters. We have the right lower quarter, upper right quadrant, upper left quadrant, lower left quadrant, right? And you should have an idea of what's in these different areas. When she was talking to me and showing me where her pain was, I'm thinking, based on the quadrants, that it may be something kidney, because I know where that placement is, right? Based on that. So you should have an idea of all the different organs are in that. When you divide it up into 9 slots, what's in each one, okay? So when I start doing my listening for my bowel sounds, I'm expecting to hear 5 to 25 sounds. That's the normal. If it's less than 5, then it will be hypoactive. And if it's above that, it's going to be hyperactive, okay? And I always listen at the lower right first, because this is where the small bowel empties into the large intestine. And what happens is, like if we shut somebody's gut down because they go into surgery or something, this is the first area that you're going to start hearing those bowel sounds come back at. So I start here and I start listening. After I hear 4, 5 at least, I move on. And I'm going to go from the lower right quadrant up to the upper right quadrant. Okay? I'm not above the umbilicus. I'm right below it, kind of right below it here. And then I'm going to go over to the left upper quadrant and down to the lower left quadrant. Okay? And so if, for example, Rebecca had just come back from surgery, and they're absent, because we can have absent, normal active, hyperactive, hypoactive, and borborygmus, bowel sounds. And so, but if she's coming back from surgery, a lot of times I would expect when I first listen to her, because we've shut it down, that we may not have bowel sounds yet. So when you chart it, you may have absent, 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 okay? Or here, maybe they're hypoactive, and the other 3 might be absent. Or you might start having active here, hypo here, and be absent here, okay? So write down, chart what you hear, okay? No guesses, just chart what you hear. That's a legal document once we put this down, all right? Now, once I do that, now I'm going to palpate after I've listened to her bowel sounds. Another thing that patients who have cardiac problems like congestive heart failure, they can have something called ascites. Ascites is where fluid, you have this venous backup in their system, starts in, it works all the way up, and it ends up in the abdomen area. And what can happen is then they have this fluid in here, and you can actually hear it. It can make like waves in the stomach, you can see it. And so I'm assessing as well for that if she would have that kind of a problem. I'd be looking for that. I'm going to do a light palpation, and I'm just going to push down. And Rebecca, if you have any discomfort at all as I'm doing this, would you please let me know? When I'm up here, I'm checking the liver, right? Stomach's kind of in the middle here, spleen over here, right? Moving around. You're thinking about where you're feeling and what's under that area, okay? Don't you do that too?
Mm-hmm.
Yeah. And I'm feeling for any kind of lumps, bumps, masses, any tenderness that she would tell me. She might go, oh, that hurts, right? And so I'm going to have her describe then what the pain is. If she's gonna, sometimes they don't call it pain. Sometimes they just say it's tender, okay? So that's what we would chart, because we couldn't put it on a, you can ask them what on a scale of 0 to 10. They say, oh no, it's just tender. So that's what you would write, and put it in quotes. Patient states tenderness in the lower left quadrant, okay? Oh, I need a drink. When I've done ascites, one of the things that we can do is we can actually cause resistance with this hand and then push with this hand, and you'll see this little wave come across if their abdomen is full of that fluid, okay? I think that's it for the abdomen. Yes?